Okay, today's check off, we're gonna do NG tube. So we'll start with co-wipe, check physician's orders, and for allergies, assemble appropriate equipment, wash hands, introduce myself to the patient, and identify the patient, provide for privacy, and educate, explain, and evaluate. This container I have is my imaginary lubrication water. And this little cup we have is his drinking cup, and I know normally they would need a straw, but I don't have one, so we'll pretend he has one. First things first is we check nasal patency. I would have him, kind of pretend to blow his nose, and then I'd also check for a deviated septum because that would interfere with inserting a tube. We'll just pretend everything's good to go for him. He doesn't have any of those issues. And he has a patent nasal passageway. So first things first is we measure it out from the tip of the nose to the bottom of the earlobe to the xiphoid process. On this little mannequin, it seems to be at about the 49 length mark. So what I'm going to do is take a little piece of tape and put it there. So that's kind of like my guideline of how far I need to insert it into my little mannequin man. I'm going to put some gloves on because in real life I don't want to touch anybody's nasal area without gloves. So for this first part of inserting, I would have him sitting up at high Fowlers and actually tilting his head back. But since this is a mannequin, he can't do that for me. We're just going to pretend he is. Lubricate my tip. Put this out of the way because it's just sticking. And then I would kind of start slowly inserting, having his head tilted back. And once he starts gagging and coughing, that's when I know we've hit the back of the throat. If I really wanted to get all fancy and technical, we could use the pin light, but we're just going to pretend like he's coughing and gagging. So at this point, I'd actually have him lean forward and kind of tilt down. And that's when we bring in the drinking cup. He'd start taking sips of water, and I just keep advancing it with each drink of water, little by little, until ultimately we either hit total resistance or I get to that little tape mark that I had originally. On the mannequin, it doesn't go that far, but we'll just pretend that it has, because in real life, we would hope it would. At this point, before I verify any type of placement, I like to go ahead and secure it to his nose because, worst case, it may come out while I'm checking some gastric sections. We're going to go up and around, trying to chevron this the best I can with my gloves, trying not to let this tape get in his mouth. And there we go. So it is taped using the chevron method. So that way it's not going to come out. There are a couple different ways we could kind of verify placement. One way is pushing air into this tubing and then auscultating his stomach to see if I hear any gurgling noise that would indicate the air has gone into his stomach. Another way we could do it is by suctioning out some gastric content and then testing the pH of it using the Lippmann's paper. And we want the pH to be between 1 and 4. And then if that's all good, a lot of hospitals also want you to just send them down to x-ray anyway, just to verify it really is in their stomach. And then if that was all good, we've done the right thing, everything's where it needs to be. I'd go ahead and close this back off, and then we'd actually secure it to the gown with a safety pin and a rubber band, like shindig mechanism, but I don't have one. It's gonna come in our kit, so we'll just pretend that it did. Okay, now let's pretend it's later on in the day, and I get an order to do some suctioning. So what we would do is we'd come in, and we turn on the device, the suctioning device, to intermittent or continuous. It depends on whatever the physician has ordered. Usually the rate is between 80 and 100 or 120. Again, it really just depends on whatever the physician has ordered. But we turn it on, take off the little cap there, and then come over here and get the tubing. And, oh, actually I do need that cap, just kidding. because it actually connects like that. So at this point, we'd be suctioning out some gastric content. We would be assessing that content, making sure that the color, consistency, and the amount is what we need. And then we could check for pH if that was something that was ordered as well. And it just depends on what the order is. Maybe he needs to have some fluid like taken off or whatever. But ultimately, we're always going to be putting that gastric, some of that content back into him. We don't want to take out too much because that could cause some electrolyte imbalances that we would not want. But after that is all over, turn this off, and then I document everything, all of my findings, how all the procedures went, how inserting it went, how the patient tolerated everything, and all that good stuff. And that's it.